over to Dr. Murali. Murali, we don't need any introduction. He's one of the very well-known glaucoma specialists from Chennai. He's going to talk to us on the diode CPC.
Thank you, Dr. Satyan, and I think it's a very nice symposium on his course on the various aspects of lasers and different situations where different types of lasers can be applied. I'm going to speak briefly on the diode cyclophotocoagulation. By definition, a difficult glaucoma, we look at what we call it, we always call it refractory glaucoma. So I was wondering what the word actually refractory means in a medical sense. It means that difficult to treat or cure. So many patients, we have to impress upon the fact that we're dealing with a difficult glaucoma, and the glaucomas can be managed in many ways. There are more than one option, and diode is one of the options. So coming back to what is refractory glaucoma, raised intraocular pressure, painful blind eyes, failure of other glaucoma procedures, post-trap, post-tube, post-keratoplastic glaucomas, post-VR surgery, silicon oil, other types of VR surgeries, glaucoma and aphakia, congenital glaucoma unresponsive to the standard therapies, and of course injuries and multiple complex eye problems in which IOP remains high and you can't really do a filtering surgery. So what are the treatment options do we have? You have a refractory glaucoma and you want to know what to do with it. I think we've been discussing in the previous instruction course, discussed about increasing the medication to maximum available medication. So 5 medicines, 6 medicines, 2-3 bottles and so on. Consider needling, considering retrap, considering even a mixed procedure, GAD procedures to go into the angle instead of avoiding conjunctival surgery and so on. We have the glaucoma drainage devices, and you also have the method of destroying the ciliary body. So maximum meds, needling, retrap, give everything a chance before you go into cyclodestruction. Consider a retrap, MIGS and GAD procedure sometimes do well when nothing else is going to work. So among the glaucoma drainage devices, you have many available in India today. You of course have the Ahmed valves. You also have the Indian modification of the Bayer valve, the RD, which is also a very good non-valve device. You also have the Ahmed ClearPath 250 and 350, which is 250 is what we get most often. And we all await the introduction of the Paul glaucoma implant with the narrow tube, narrow inlet into the device, and the PGA is not yet available, but we await the. But what happens if you do an AGV? What happens if you do a glaucoma drainage device? This paper I found looked at the 5-year long-term outcomes, and it does quite well. Most of our patients do quite well, and we look at our own patients over the last 8 years, 10 years, and so on. This is a published series of IOP maintaining itself in more than half the patients who had the glaucoma drainage device. Cyclodestruction is to reduce the intraocular pressure by destroying the ciliary process located in the pars placata region of the ciliary body. But it is not the procedure of first choice for any kind of glaucoma generally, and was reserved as a last option for uncontrolled glaucomas in patients with poor vision potential. But we are now considering it as a limited diode, and even the micropulse is being considered for patients with seeing eyes. So in the past, we had procedures like cyclodiathermy, beta radiation, and for those of you who are studying and fellowship and students, I think this is of interest. Cycloelectrolysis, even microwave was used to destroy the ciliary body, and so all animal studies, nothing really went into clinical practice. Cryotherapy was used for a very long time. We've all done cryotherapy for many, many years before switching on to the lasers. And certain centers, the high-intensity focused ultrasound is also available, but is not commonly used in many centers. You can also deliver the energy through the transcleral route by contact method, transpupillary non-contact, and also deliver it intraocular by endoscopic methods. So historically, the xenon arc, the ruby laser, and the Nd:YAG laser have been tried, and the krypton laser also was tried for cyclophotocoagulation. But the semiconductor diode of 810 nanometers has become the most commonly used procedure today, after American Academy's technical report recommendation that it has lesser energy, better absorption by the uveal melanin, quicker, durable, and also portable and lower maintenance costs. I think my own diode laser is now with me for about 18 years, and I still keep using it. I've only been changing the probes. Of course, a periodic service. The mechanism by which the IOP reduces is reduced aqueous production, destroying the ciliary epithelium and reduced vascular perfusion, and also maybe an increased aqueous outflow pars plana or transscleral cyclo kind of an outflow. So that is also a possible hypothesis or mechanism by which the IOP gets lowered. If you look at the Cochrane review, which looked at a lot of papers and kind of analysis of many published articles on the cyclodestructive procedure for refractory glaucoma, the evidence actually was not conclusive as to whether one procedure is better than the other. But what was very clear was that the common side effects were there: hypertony, phthisis bulbi. And what was not reported commonly was the patient's pain, quality of life, and these, I think, should be study and important, or what we should say, parameters to be measured as outcomes in future trials. But whether one type of cyclodestructive procedure is better than the other is not very clear after this Cochrane review. So we have left our own choices as to what we can offer to a patient, whether we want to do a reprocedure, whether we want to do a glaucoma drainage device, whether we want to consider a limited diode, and so on. So I have been using the transcleral diode laser with the G probe for many years now, more than a decade. And the G probe, as it is called, it's a fiber optic tip, 1.5 mm, it protrudes, and behind the kept 1.5 mm behind the anterior edge of the foot plate and protrudes about 0.7 millimeters. The tip is a little bulge in the foot plate. And the general settings, this is some of the standard settings. About 1500, 1800 power, about 2000 is the milliseconds, and then you can keep it in repeat mode if you want, and keep doing the laser. Generally, we do not do 360 degrees. We always end up with 180 degrees. Very rarely I have done 270. Always give a peribulbar block or a local anesthetic block. Have a monitoring of the patient, and informed consent is extremely important, and it is done with all the precautions of how you do a surgery because of you given the block. It's a continuous wave energy delivered to the ciliary body by a laser probe kept about 1.2 millimeters behind the limbus. The G probe is the name of the device. I think there are other companies which make the same device, but the one I am using is called the G probe. 2000 watts for 2 seconds is actually maximal. And if you hear the pop, an audible pop is sometimes heard. This actually pop is a micro explosion or the ciliary process. Once that happens, you obviously know the energy is too much. You scale down the energy and start using lesser energy. And do not treat, again, as I already said, do not treat more than 180 degrees in one session. You're going to have risk the chance of hypertony and phthisis. Very high incidence can be there. Post-operatively, you need to give cycloplegics, you need to give some systemic analgesics for comfort. Steroids, yes. I sometimes continue glaucoma medication, but a little less number of glaucoma medications, but don't stop all the glaucoma medication. My favorite is to go brimonidine timolol combination, and I stop the pilocarpine and prostaglandin if the patient has been using it preoperatively. Transient IOP rise common, pain, uveitis, hyphema, hypotony, choroidal detachment, phthisis. You should be prepared for any complication which you may be surprised by seeing it the next day. Be prepared, maybe an hour later, evaluate the patient. Evaluate the patient the next day to the extent possible, as far as possible, and then keep following up the patient closely. And you will sometimes find in children, juveniles, in certain types of eyes with distorted anatomy of the ciliary body and the limbus, you will find it's difficult to locate the ciliary body. Routinely doing it 1.2 millimeters behind the limbus is not correct. You should actually transilluminate, and there are many papers which will tell you the ciliary body position as identified by transcleral or transcorneal transillumination will tell you the dark area of where the ciliary body could be. So treat the ciliary body and don't just blindly treat 1.2 mm behind the limbus. Intraocular endoscopic CPC is another option, and this is actually directly visualizing with a single probe, which you can actually look into the eye, look at the ciliary process, and directly pop off the ciliary process one by one wherever you want to see it. Aphakia, pseudophakia, it has to be vitrectomized, and a limbal or pars plana route is also possible. Visualize it. And the ECP probe made by a certain company actually is an expensive machine, combines a diode endolaser, an aiming beam, a light source, an endoscope into one single probe. The single probe, which has all of this into one single probe, allows for a targeted, controlled ablation of the ciliary process, direct visualization, and titration of the power. Can be combined, the ECP can be combined with phacoemulsification surgery. There are many publications on this. The reports of IOP reduction range from 2 to even up to 10 millimeters of mercury with ECP alone, and a much higher with the cataract surgery is combined with the ECP. This is actually a meta-analysis, a paper which looked at the differences between the aquashunt and the ECP. And if we look at this particular paper, it really showed that between ECP and the aquashunt, there's not really too much of difference. Provided, of course, you have the device and you're combining it with the cataract surgery, and of course, you have the luxury of having a retinal surgeon who can actually handle the probe. The micropulse, I think Dr. Prasanna is going to speak about the micropulse. Now I have switched to the micropulse diode laser now, and I think he's going to talk more about that. The histopathology of what has been published very clearly shows that the extent of severe damage which you used to see with the continuous wave is not seen with the micropulse. So I think it's a clear advantage. This is the way I do the micropulse. And the take-home message, Prasanna will talk more about the micropulse laser. The diode CPC is an option for refractory glaucoma. The continuous wave TSCPC is reserved for non-seeing eyes. Phaco ECP is a good option in certain situations. And the micropulse is probably the way forward and in seeing eyes. But mind you, the bottom line literally is that cyclodestruction is not a primary procedure of choice for glaucomas. Don't offer it primarily to any glaucoma patient. Thank you for your attention.